Hi everybody, I'm Dr. Deed Harrison from Chiropractic BioPhysics Technique and CBP Nonprofit, a spine research foundation. This week's video research review is video number 45, and it discusses a recent case study just this month that we had published in the Chiropractic Journal of Australia. This is titled Alleviation of Radiculopathy by Structural Rehabilitation of the Cervical Spine by Correcting a Lateral Head Translation Posture, which is a right head shift in this case. That's what negative TXH means, a right head shift, using the Berry Translation Traction Table as part of CBP or Chiropractic BioPhysics methods. This is a case report put out by my good friend and colleague, Dr. Bob Berry up in New York, my colleague, Dr. Paul Oakley in Canada, and then myself, Dr. Deed Harrison here in Eagle, Idaho. Now this was published in the Chiropractic Journal of Australia, March 2017. Just to give you a background, in the late 1980s, my late father, Dr. Don Harrison, was looking into human biomechanics and how to improve chiropractic practice, chiropractic science, and merge the gap between chiropractic ideas and philosophy and how to actually achieve health and well-being through spine correction, which in his day, nobody was truly correcting the shape of the spine and nobody was looking at proper biomechanics the way we do today. So he was somewhat of a pioneer in the chiropractic profession. Well, what he did is he looked at one of the founding textbooks, or one of the pioneer textbooks in the field of spine biomechanics, and this was done by White and Punjabi. This came out in the 1970s. It was called Clinical Biomechanics of the Spine. In that textbook, there was a three-dimensional Cartesian coordinate system like used in any math and engineering and physics, where they applied this three-dimensional Cartesian coordinate system, X, Y, and Z, to a functional spinal unit of two vertebrae. So we have one vertebra on top, a disc, the ligaments, and the vertebra below. And White and Punjabi said this functional spinal unit, the vertebra above relative to the vertebra below, has 6 degrees of freedom, 3 rotations and 3 translations. They then said there are 12 simple motions in 6 degrees of freedom, meaning that a vertebra can go forward and backwards on each axis, X, Y, and Z. And it can rotate forward and backwards, or left and right, or turn left and right, tip left and right, excuse me. So we have 6 rotations, 6 translations in 6 degrees of freedom using a three-dimensional X, Y, and Z Cartesian coordinate system. 6 rotations, 6 translations. Now translations are linear movement, rotations are angular movements. Well, what my dad noticed is no one had applied that Cartesian coordinate system that White and Punjabi applied to a functional spinal unit. Nobody had applied that to human body posture. So my father, in the early 1980s, was actually the first person to do that. Shown here is his image that he developed in the early 1980s showing 6 rotations and 6 translations. Now, in my father's day, no one was discussing these translations. People were discussing these rotations, but not necessarily using a proper Cartesian coordinate system. Flexion is rotation forward and backwards about an axis that passes through your shoulders. It's a coronal axis, so I can bend forward and bend backwards. Flexion is a positive rotation, extension is a negative. This is left and right lateral flexion. This occurs about an axis coming out, let's say, of the episternal notch in the sagittal plane. So you're tipping left and right around a sagittal plane axis. Now, tipping right is a positive motion, tipping left is a negative motion, the way it works in a Cartesian coordinate system. And then we have rotation about gravity, what we call rotation Y. And by the way, these two are mislabeled. This should be RY, this should be RZ. Sorry about that, we just transposed them in the figure. Not to mention names, but my good friend Dr. Joe Ferrantelli did that, and he has not fixed it for me in about 10 years. So now you're on a YouTube video, Joe. Anyway, back to this. This is turning to the right, which is a negative y-axis rotation. This is turning to the left, which is a positive y-axis rotation. This occurs about an axis that runs right down through the midline of the body vertically. You're rotating around gravity. Now, these are the 6 rotations. Okay? We have 3 degrees of freedom, meaning we have 3 axes we can rotate around. But then we add the plus and the minus. That's 2 directions in each degree of freedom, so we have 3 times 2 is 6. These rotations were known in my father's era. He's the one that first developed these translational displacements. He said, look, translations are linear movements. They're not like rotations. We also have 3 degrees of freedom, and we have 2 directions on each axis, so 3 times 2 is 6. Look, I can translate my head left and right. This is about an axis through the shoulders. This is the coronal plane axis. This is my vertical axis, up and down. That's translation Y. Up is positive, down is negative. And then forward and backwards is translation in the sagittal plane. Forward is positive, backwards is negative. These translations are very important for human body analysis, human performance, human function, etc. This particular case, we're going to describe a patient that has a right head translation called a negative translation of the head on the x-axis. The patient was not properly diagnosed previously, and this, in fact, we believe led to the problems that the patient developed. So this right head translation, what do we know about it? Well, my father was the first to report it in his textbook. However, he didn't report it in the scientific literature. His textbook was indexed and has copyright and was indexed through the National Library of Medicine, so it's a properly published textbook. However, a peer-reviewed journal article did not come out on this head translation until the year 2000. We, in fact, did this, looking at how head translations affect the human spine. Well, in clinical biomechanics in the early in 2000, we studied this. We showed people with left or right head translation, they develop an S curvature in their neck when we look at it from the front or the back. This S curve is shown by the lower segments tilting or bending to the side of head translation, in this case the right, and then the mid and upper neck joints, including the skull, tipping to the left relative to the direction of head translation. So if I translate to the right, these segments here in the head are tipping to the left relative to the lower neck and relative to the side of head translation. This is what a real x-ray of somebody looks like with this position. Now, A is shown from the front. You're looking what we call from anterior to posterior. B and C are in fact looking the other way. We're looking from the back of the person. That's why it looks different. This is the spinous processes we can see. This is why we see the face here. That's from the front. These two are from the back. Okay, so we quantified what the neck does and looks like when you have a head translation. The problem is we're designed to move in this position, left and right. We're not designed to be stuck like this. Now imagine if you had a head translation from an accident or an injury or poor postural habits, and your neck now is stuck in this position. You're going to have to move from this position. Your head is shifted over, and now when you do things, you're moving from this abnormal static starting position. The muscles, the ligaments, they're all in an abnormal position. The nerves, now when you move, you do things, you're active. You are going to develop problems due to asymmetrical loading and movement based on this. Okay, this is what we have to realize. So this report describes a patient that has a chronic lateral head translation. This is a 57-year-old male with right arm pain and neck pain. So radiculopathy down the arm. Now true radiculopathy is not just pain down the arm. True radiculopathy means I have weakness in one or more of the muscle groups depending on what nerve root is affected. So we should see something like there's bicep weakness, or there's forearm weakness, or there's triceps weakness, or there's grip strength weakness. We'll see what this case has. Also, we'll see a reduction in reflexes in the same motor unit that nerve root innervates. Is it the bicep reflex? Is it the triceps, etc.? We'll see what we have. Hyporeflexia. Also, In more moderate to severe cases, we'll have sensory disturbances where when we touch the skin, the person does not have proper sensation. They don't feel light touch. They don't feel temperature and pain, etc. Now, this person has a history of motocross injuries when he was younger. Now, you can imagine motocross injuries. He's probably taken a few crashes, probably hit his head and neck. How did he get this head translation? Well, you're looking at one of the most obvious reasons. Now, we don't have an x-ray of him before and after a motocross injury, but we do know that's probable, right? What is the most probable thing? That's it. He has decreased neck flexibility, numbness down his right arm and into his hands, weakness in his right hand grip strength. We'll see how weak. He was upset because he could barely hold a large diameter pin to sign checks and sign for building materials that he had to do for his job. In fact, what he had to do is he had to wrap tape around the pin to give it more volume so he could adequately grip it. So obviously his fine motor is diminished and his total grip strength is diminished. Okay? And he has a chronic history of this. His blood pressure is 135/82. Borderline, I mean, that's still within normal limits, but let's be realistic. If somebody has a good diet, they exercise, and they're in good health, their blood pressure will actually be lower than this, okay? It doesn't reach the threshold of true hypertension, but as a healthcare provider, I can tell you that this should be more like 120/65, 120/70, or even 110/70. When you look at an athlete that's conditioned, their blood pressure is much lower, so keep that in mind. The orthopedic tests were positive for cervical compression. What that means is when we compress his neck, he gets arm pain down his arm. Also, the lateral compression tests are worse on the right, where we tip somebody's head over and we put pressure down to mimic pressure on the nerve root. If the patient goes, whoa, then we know we do truly have cervical dysfunction. We have some kind of a bone spur. We have a disc herniation, some kind of space-occupying lesion in his neck. This is proper differential diagnosis. His range of motion using proper digital range of motion in degrees. Flexion is 56 degrees. Extension 57, those two are really classically within normal limits. Left lateral flexion and right lateral flexion is reduced. So really the main reduction in range of motion is bending to the right, and that makes sense. He has right arm pain. Dynamometer testing, this is where we check the grip strength. Now his left hand is 101.4 pounds of grip pressure that he can use and squeeze. Now this gentleman is right-handed. If you're right-handed, guess what? His right hand should be more like 110, 115, maybe even 120. Guess what his right hand is? 54! This is a dramatic reduction in grip strength. We've got involvement of the nerve root going down into these forearm hand muscles. He cannot grip. No wonder he can't hold a pin. He's got more than a 50% reduction in his grip strength. Now let me give you the reality of this. This is a true nerve injury where we have damage to the nervous system, true nerve compression. Okay, this is truly bone or disc on nerve. This is a problem. If we can't address this with corrective care, he's going to have to go in and have surgery. If he has severe atrophy of these muscles, he absolutely needs to go and have decompression surgery. Okay, now this case, it's not that far gone. He doesn't have major volume loss in the muscle. If it's volume loss, we have to send you out right away. You have to get decompression surgery. It's the only way that's going to come back, right? Now also, you got to be concerned about grip strength. If it was a bilateral loss of the grip strength in an older subject approaching the 6th decade of life, this relates to early death. Okay? Grip strength is a very interesting assessment. If for your age group, both of your hands are well below normal for your age, either you're really, really weak for whatever genetic reason, or you've got something systemic going on in your body, and you better be concerned about that, by the way. Okay? Numerical rating scale. He's a 6 out of 10 at his worst. Now that's approaching severe, not quite. That's at the upper end of moderate neck pain. Pretty intense. He's got tingling and numbness down both arms, primarily in the right. His average neck pain, average day-to-day, every day he wakes up, he's a 4 out of 10. That's moderate neck pain. His severe is a 6 out of 10. The neck disability index, he's scoring an 18%. Now that's not that high per se, but that's because most of his problem is not neck pain, it's Grip strength problem. So if we had a hand dysfunction questionnaire, you would find out he's really severely limited. If you can't even grip a pen, you got issues. Imagine this. He goes to grab a glass of coffee, he's probably going to drop it. Some of you out there have probably experienced that yourself. That's not something you want to ignore. There's something going on. When you can't grip something and you're dropping things, or you have to consciously go, God, I got to squeeze really hard to hold this. There is something wrong. You better get checked. Lateral cervical x-rays. The head is forward, and we have a reduction of the cervical curvature. So this x-ray was taken 6/29/2015. Forward head posture of 40.1 millimeters. That's out there. The average asymptomatic person in the adult population has 15 millimeters of forward head posture. This is almost 3 times that. Okay, that means this point on C2 should line up on this green line back here. That's 41 millimeters forward, and he's way above population normals. The cervical curve is 29 degrees. Ideal is 42 degrees. Average is actually between 30 and 40 degrees. His neck curve is actually pretty reasonable. It's really the forward head posture that's the culprit. And then notice right here, right between 4 and 5 and 5 and 6, there's some disc damage and disc thinning. We likely have some bone spurring in there. We likely have a mild to even moderate disc herniation, etc. Now, this is the culprit that we also want to look at. This is the P to A x-ray, looking at the patient from behind. This gentleman has a significant right head translation. How far? 15 millimeters to the right. Now, when we look at chronic pain subjects, we've done a study in 2004 or 2005. I went through it already with you previously in these videos. The abstract was in the Journal of Chiropractic Education. We showed that the average person with neck pain has roughly 12 millimeters of head translation. He's just above that. He's at 15. The larger your head translates over, the longer you've had neck pain, the more disability you will have. That's what we found in that study. He is fitting this scenario. Okay, so 15 millimeters of right head translation. So what are we going to do? Well, we're going to see the patient under CBP protocol. We're going to put them on a rehabilitation protocol to improve their head and neck alignment and full body function and full body alignment when needed. 36 sessions over 12 weeks. We're going to see the person 3 times a week for 12 weeks. And some people go, that's way too many. Way too many. I look at it and I go, really? Have you ever tried to diet? What do you do? Diet 2 days a week for a week and you're done with the diet, right? You're all better, right? Or, hey, I want to exercise. I want to exercise and get in shape. Well, you know what? Let's exercise once a week for 5 weeks and we'll be all better, right? We'll be fit. We'll be able to do exactly what we want. You know what? This is nonsense. This idea that chiropractic is only 2 to 4 weeks, 2 to 5 times per week for 2 to 4 weeks and you're all better, forgive me, but that's bullshit. It's absolutely bullshit. It's the only word I can use for it. You know, when you look at human health conditions and problems in people, you have to break habits. You have to change habits. You have to change patterns. You have to work hard to change physiology and function in the body. You cannot just do this in 2 to 4 weeks. In fact, 36 visits is just the tip of the iceberg for some people. 3 times a week for 12 weeks. And if I offended you with the word, bleep me out. Don't listen to it. It's just the reality of it. We're going to do full spine manipulative therapy. We're going to do mirror image instrument and drop table adjusting to correct the spine. That's why we call this adjusting versus manipulation. This is for the joints, to get the joints to work. This is classic chiropractic. This is where we're correcting the body using CBP mirror image methods. We're going to do mirror image cervical translation exercises. We're going to do prone drop table adjustments and cervical lateral translation traction in the mirror image. Here's what these things look like. So the head and neck are translated forward in a mild loss of cervical curve. Here's the x-ray. Here's the mirror image adjustment. Maybe you don't want to put quite that much extension in there. I didn't have the right photo. So you actually tip the headpiece back down a little bit and tuck the chin down so you get more of a translation. And then we thrust at the apex of the curve or in the upper thoracic region to create translation. This is the setup for correction of right head translation. The patient has a right head translation, so we lie them on their left side, we let gravity work with us, and we push their head and neck and upper thoracic spine down into the correction position called a mirror image adjustment. My father is the first person to develop this technique in the history of actually healthcare. You can look that up. So mirror image adjustments done 3 times a week for 12 weeks. Here's the mirror image exercise. This is the actual patient doing it. If his head is translated to the right, we're going to teach him how to control his head and neck and use the muscles and appropriately shift his head and neck to the opposite side. This is not a rapid movement. This is a controlled, slow movement. Get into the position, make sure it's correct, hold for 3 to 5 seconds, come back to neutral, repeat that maneuver for at least 5 sets of 10 repetitions. Better to do 5 sets of 20 repetitions. So we want at least 50 to 100 repetitions per day. Now we can't start them at that high of a frequency or a number of repetitions. So what we do, we start with 1 set of 10, we make sure he's okay, and then over consecutive days or visits, we increase the number to where we're getting 50 to 100 repetitions of that exercise. And sorry, I left the laser light right on his nose. That's hilarious. Anyway, sorry about that. This is the Berry translation traction. The coolest thing ever is our good friend and lead author on this, Dr. Bob Berry. He actually developed this table for his practice and for CBP Technique. Now in the past, we've done a non-randomized clinical control trial on this traction. We know it works. We know it corrects the body. We know that. Bob is using this in his practice as well for his patients with this, and he's been using it for several years. Roughly, this was developed in the late 1990s. This is lateral head translation traction. Put the head in these nice head padded clamps. You're laying on your back. We slide your head over into the mirror image as far as the patient can comfortably tolerate. Keep you there for 3 minutes. Then we build up to where we're doing 10 to 15 minutes per session in this translation traction. Now you'll notice the headpiece has a little tip to it as well, but the patient's head is not tipped. When you translate over, the person tries to tip to that side, so you control that by tipping the apparatus back. So we're not really creating lateral flexion of the head, we're trying to minimize the left lateral flexion and make it pure left translation. So mirror image traction was done as well. Now this was done 12 weeks, 36 visits, minimum of 1 day with no treatment. Better to do this 3 or 4 days with no treatment, we reassess. Look at the x-rays now. The x-rays are dramatically improved, okay? In fact, it's a little bit overcorrected. The green line is center. Now he's slightly shifted to his left by a few millimeters, okay? 3.9 millimeters. That's actually a good thing, because he'll normalize a little bit back the other way towards center. So we actually like to see a little overcorrection in an adult if we can. Now this is a great outcome. What did that mean for the patient? Well, let's really see what it means. You see hints of it up here. He got full hand strength back in his right hand. Cervical x-rays showed improvement in that head and neck posture, but the reality of it is, what does it mean to a patient? See, this is to the doctor, to the CBP chiropractor, we love the x-ray and we love looking at people's posture. But the patient, that's okay to them, but what does it mean to them? Well, here's what it means. Here's a quote. This is what this guy said. Quote, "I'm glad that I found my chiropractor," talking about Dr. Bob Berry, "after all these years. He saved me from going to a hand surgeon, which he had a visit with. He had a scheduled appointment with to have surgical intervention. So he had already been to the hand surgeon. That was the option. We're going to cut your flexor retinaculum open and give space for that median nerve." Okay? In reality, there might be a problem in the hand, but you got a problem in the neck. Cutting the hand open isn't going to fix the neck. Okay? It's not going to happen. It makes sense to me to try neck correction before you go in and slice open the hand. Now, I'm not saying people don't need that in some cases. What I am saying is there's something called a double crush injury. If you put pressure on the nerve up here, when it comes down and then you put a little pressure here, now I'm going to get moderate to severe symptoms distal to the last site of compression here. People think this is the problem. In fact, this may not be the problem. It may be up here. It's called a double crush. Let's fix this, then we'll think about this, okay? So he says, he, Bob, Dr. Bob, saved me, and I have my hands back so I can continue my work. Neck pain was reduced from 6 out of 10 to 0 to 1 out of 10. That's amazing. NDI was reduced from 18% disability down to 0 disability. Range of motion, flexion improved, even though it was within normal limits for his age. Look, it improved. So maybe what's called normal isn't actually ideal for a person, because when you start working on them, their range of motion improves. Wow, that's a novel thought. Extensions improved. Left lateral flexion and right lateral flexion improved. Even though this was within normal limits to the left, look, it's now improved to 62 degrees. Can you imagine a guy in his late 50s can move his neck that far? That's amazing. He didn't even know it was reduced probably. This is the big one. Hand dynamometer strength. Look at this. Initially, the weak side, the right hand, was 54 pounds. After 12 weeks of care, 111.3 pounds of grip strength pressure. He's doubled his grip strength pressure. That's from working on his head and neck. It's dramatically improved the nerve, which translates into improved grip strength function. You can't make this stuff up. Now, this is why this case is a very, very good case report. The person has a chronic history of dysfunction. It's not just something that happened yesterday. It's a chronic history. He's getting worse. In fact, he's been recommended to have surgery. Now you do corrective care, you improve the alignment of the head and neck, and you repeat validated assessments, grip strength. You can't cheat on that. You squeeze and you don't know what normal is for your age. And you have a left hand that should be weaker than your dominant hand, and now it's the other way around. 12 weeks later, totally improved. 100% normal function now. That's amazing. That's why this case was published, in my opinion, in the Journal of Chiropractic, or the Chiropractic Journal of Australia. They saw the value of that. So thank you to the editorial board, thank you to the review board, and thank you to the editor for finding that this project was worth publication. I think it's very important. There's many, many people out there like this. They don't know that corrective care can improve them. They have no idea. What they do is they try generic things. They do drugs, and they might do a little bit of rehab here and there, but they're not getting their neck corrected. Then they end up in surgery. And while surgery does help some people, it may not be needed in many people. If we can correct the head and neck and prevent a patient from undergoing surgery, to me, that's one of the greatest things as a healthcare provider, right? I know many surgeons, and many of them say, yeah, surgery should be the last resort for these people unless it's an overt emergency where we have serious dysfunction going on. Try other things first. We believe that correcting the lateral head shift posture in this case, using the Berry translation traction and CBP mirror image methods, adjusting and exercise as well as spinal manipulation, decrease the spinal nerve root tension and compression, releasing its intermittent impingement, and subsequent arm numbness and hand weakness in this patient improved. Hopefully you enjoyed this simple case presentation. If you are somebody out there that has something like this, or you know somebody like this, hey, you know what? Let's send them to a CBP trained chiropractor. Let's see if there's something we can do to correct the head and neck and the human spine before somebody commits to having surgery, unless it's an absolute, emergency or an absolutely serious issue where they need it now. And I've talked a little bit about what that would be, atrophy of the muscles, things like that. In this case, it's obvious that the patient didn't need that. This case just needed a head and neck correction, and it improved his signs and symptoms, and that's the most relevant and important thing. If you're a CBP chiropractor out there, hopefully you continue to follow our work. If you're not, and you want to be interested in providing this type of work, come to one of our educational conferences. Go to idealspine.com.